now we'll talk about a very important topic. For a surgeon, the instruments are his tools and the theater is his sanctum sanctorum, right? So that's where we do our surgeries. That's our place of worship. And let me just take you into the journey of the surgical instruments. And what I'll do is I will show you these instruments, how we actually use them in the same order in which they're used in the theater, so that it becomes easier for you to remember. Also, when you're asked in the surgical viva, when you're asked about a surgery, sometimes the examiner does ask you the sequence in which you'll use the instruments. So this would also make it easier for you to understand them. Now, the first thing when we enter the theater, we've discussed in general surgery, once the patient is anesthetized and ready for surgery, we first have to clean the part. And to clean the part, we have discussed we can either use chlorhexidine alcohol solution or we can use povidone iodine. So to clean the part, the surgeon or the assistant is going to use a Rampley's sponge holder, right? So this is the first instrument, the Rampley's sponge holder. Now, before I tell you about the Rampley's sponge holder, let me just briefly tell you about the various parts of a surgical instrument. And I will tell you these parts once, I'm not going to repeat them in all the instruments. So you can see here that these are the two rings, right? These are the two rings of the instrument, right? And in these rings, you basically insert the thumb and the ring finger. And the other two fingers are used to support the instrument, okay? So it's not the thumb and the index finger because that leads to restricted wrist mobility. It is the thumb and the ring finger gives you enough mobility then, and you can use these two fingers to support it. You can also see that there are multiple ratchets here, right? And why do we have these ratchets? You can see these ratchets get locked. Why do we have multiple ratchets? Sometimes examiner asks you this. This is to allow for the wear and tear of the instrument, okay? So usually we just use one ratchet and that is enough. That closes the instrument. But as the instrument gets old, sometimes there can still be a gap after using one ratchet. So in that case, we use multiple ratchets, okay? But in the theater, whenever you're trying, just try with one ratchet first. Our professor, one of them, was very harsh on us. If he used to hear this sound in the theater, he used to get really annoyed. So single ratchet should be used. If that's not working, you use one more ratchet. This is the handle. This is the handle of the instrument. And these are the blades. Now the handle and the blades are joined, in this case, by a box joint. Right? So this one is a box joint. There can be two types of joints. This one is a box joint. And here you can see this one is a screw joint, right? So this is a box and this is a screw. You can see the screw here and this one is a box joint. So what is the difference and why do we have these two kinds of joints? The problem with screw joints is that you can see the screw here. The problem is that sometimes threads can get stuck here. And this must have happened to you if you're suturing. Sometimes the thread gets stuck in the needle holder or one of the instruments with the screw joint. It can happen in a box joint as well, but happens more commonly with the screw joint. The next you can see the blades of the instrument. And now let's talk about this sponge holder. So the sponge holder, as you can see, the blades, the ends are fenestrated. There is a fenestration. There's a gap in between. And you can see that there are transverse serrations, right? I hope you can appreciate the transverse serrations here. Now, whenever you have transverse serrations and when you use the ratchets, then that's going to crush the tissue, right? So if you hold some tissue with this, it will have a crushing effect on the tissue. And as the name suggests that this sponge holder is used for holding a sponge or a gauze piece and then to clean the part. So this is my sponge. I'm going to hold the sponge with this and then I can use it to clean the part. Okay. Now we've already discussed in general surgery that if I'm preparing the part, supposing I'm doing abdominal surgery, then I have to clean the part from the nipples to mid-thigh in males. And we'll go from midline laterally in the abdomen and lateral to midline in the thigh. Lateral to midline in the thigh. Also, I've told you previously that supposing one more way of cleaning the part is supposing there is something over the forearm, then I can clean the incision site and then I can go circumferentially outwards. So this was our first instrument. This is a Rampli sponge holder. You should be able to identify this. Now once I've cleaned the part, then I'm going to drape the area, right? Then we are going to drape the area, and you have seen we can either use plastic drapes or we can use cloth drapes to cover the incision site and to cover the operative area. Now to keep those drapes in place, we will use a towel clip. This is, you can see here is a towel clip, and this one also you can see 2 rings there, the ratchet there, there's a box joint, and you have 2 hook-like things at the end, and when you press them, they overlap. So they're going to grip the cloth tightly, right? They're going to keep the cloth in place. So the one with the ratchets is known as Mayo towel clips, and a one with a pinchcock effect. You can see in the image, the one with the pinchcock effect is known as a Doyen's towel clip. Now, what are the other uses of a towel clip? One, I've told you they are used to hold the drapes together. You must have also seen the suction and the cautery, and that suction and cautery are also clipped with the sheets which are used for draping. So you can use a towel clip and you can pass the cords of the suction and the cautery through this, and they can remain attached there and they won't fall down. So those are the various uses of a towel clip which you should know about. So now once our draping is done, we've cleaned, we've draped, now we are ready for surgery. And when we are ready for surgery, we've discussed that the surgeon has to use a knife and a blade to make the incision. So the blade is mounted on a BP handle. This is asked quite frequently in the exam. This is a BP handle or a Bard Parker handle, right? BP or Bard Parker handle. And this is where the blade comes. You will get the blade here, and then the surgeon can use it to make incisions. We've discussed in the past that whenever you have to pass a knife or a blade, always done in a kidney tray. Always done in a kidney tray. If you don't have a kidney tray, then you'll always pass it with the pointing end or with the sharp end pointing towards you. Even if it's your enemy, never with the sharp end facing towards the person. The sharp end should always be towards you. Now to make an incision, there are various grips which are there. Commonly used grip, you can either hold it like a paintbrush, you can use it like a pen, or you can even have a palmer grip. You can palm the blade or palm the BP handle, and then you can make an incision. Okay, so hold it like a paintbrush, hold it like a pencil, and you can make an incision, or you can palm it and then you can make an incision. Okay, we've already discussed that if I'm left-handed, my incisions are going to go from my right to my left. My right to my left are going to be my incisions. If you're right-handed, then they're going to be from your left to your right. For left-handed people like me, it's going to be from my right to my left. Okay. So this is your BP handle where you mount the blade. We've already discussed the various blades and the uses of those blades in the general surgery module. So please refer to that module for the details of those blades. Now, once we make an incision, there is invariably going to be bleeding. We've already discussed the use of a cautery in the general surgery module. We've discussed monopolar, we've discussed bipolar, we've discussed harmonic scalpel and ligashot there. So for details, you can refer to that module. Now, when there is bleeding, you can suction the blood using a suction catheter. Now, this metallic suction catheter is known as a Yankauer suction catheter. It's a Yankauer suction catheter, and it has a small opening through which you can suck blood or secretions. And I want you to observe this small opening here, a small hole here. So when I press here, that's when the suction gets created and it will suck effectively. If you don't press here, the suction is not that effective. Okay. The small mouth prevents large tissue getting sucked inside and prevents trauma. I'm sure in the theater you must have seen bigger plastic suction cannulas as well. So when bleeding happens, that's where we use the suction catheter. Even for oral suctioning of saliva after surgery, this catheter can be used. So after the incision has been made, we now have to retract the tissue so that we get better exposure and we can carry out a surgery. So let's talk about some of the retractors. Now when I talk about retractors, there are two broad divisions of retractors. And I want you to remember this because this has been asked frequently in your MCQ exams as well. So we can either have non-self-retaining retractors or self-retaining retractors. So the terms are self-explanatory, right? Self-retaining, they will remain in place even if you don't touch them or do anything to them. Whereas the non-self-retaining retractor, you need somebody to retract them, which most of the times is the intern or the first year postgraduate. Okay? So the first thing which I want to talk about is a skin hook, right? So this one is a skin hook. And you can see here that there is a single hook here, whereas you can have a double hooked skin hook as well, right? This one has two hooks, this one has a single hook. And these skin hooks are used for raising the flaps. These skin hooks are used for raising the skin flaps. That's what we use them for. So supposing I'm doing a mastectomy or I'm doing thyroid surgery, once I have to raise the skin flap, one assistant is going to hold these skin hooks and then I'm going to dissect my flap, right? So these are skin hooks which you should know about. So another retractor used for retracting superficial tissue is the cat's paw retractor. So you can see here, this is the cat's paw retractor. You can see that the end is curved. You can see that the end is curved and it's in the shape of a cat's paw, right? You have these multiple prongs coming out from there. And the advantage is when you retract, it hooks the tissue and you can pull it back easily. So it hooks the tissue and you can pull it back easily, but this is only for superficial structures. If you're doing a superficial surgery, doing a surgery in the palm, sole, or if you're doing a thyroid surgery, or if you're removing a sebaceous cyst or a lipoma, you can use a cat's paw retractor. For slightly more deeper retraction, you can have a Zernes retractor. This one is a Zernes retractor, and I want you to observe this instrument. This has been asked quite frequently in the exam. You can see here that this has a handle. You have a handle which is fenestrated. And why is this fenestration there? This fenestration is there to make the instrument lighter and to improve the grip, right? To make the instrument lighter and to have a better grip. Now you can see that one of the blades here is a solid blade. You can see it's a solid blade. There is no fenestration in between and it is at right angles. It is at right angles with the handle and you can see that there is a small hook at the end. It's slightly curved at the end. So the advantage of it being curved at the end is that it hooks the tissue and you can easily retract it. If it was straight, tissue will keep on slipping out. Tissue will keep on slipping out beneath it, right? So this is also used for superficial tissues. Also when you're retracting the abdominal wall, when you haven't incised the peritoneum as yet, you're retracting the abdominal wall, you can use this. The other side you can see there are two prong-like things and there is a fenestration in between. There is a gap in between. Now why is this gap there? This is very important for you to understand. Supposing I am retracting the rectus sheath and now I want to close the rectus sheath. So in general surgery, we've covered about rectus sheath closure. We know it is done using the Jenkins theory of mass closure and you're going to use a Prolene suture and it has to be 4 times the length of the wound, right? All these are very important questions. But the first bite of rectus sheath closure is the most important. Right, you will often see that the senior resident takes the first bite and then he will hand it over to the postgraduate to close the rectus sheath. And why is the first bite important? Because I want to take the first bite, supposing this is the cut, my finger is the cut in the rectus sheath. The first bite I want to take beyond the cut so that I include the entire rectus sheath and it does not open up. So the advantage is that I can retract. And because there is space, I can easily use my needle in between this space to take that bite. Whereas if it was through the solid end, I won't be able to see where my needle is going. Here I can see where my needle is going and I can take the bite easily. So this is a Zernes retractor. You should know about it. Now, this is a Langenbach retractor. You can see here, this is a Langenbach retractor. And again, this Langenbach retractor has a handle, has a fenestration. We know these fenestrations are to make the instrument light and to improve the grip of the instrument for the person who is retracting the tissue. Again, you have a blade which is at right angles, and there is a slight curve at the end so that the tissue does not slip. Now, you know, Langenbach was one of the first to perform a cholecystectomy, an open cholecystectomy, and he used this Langenbach retractor to retract the liver. The problem was that the blade was quite narrow. You can even see here that the blade is quite narrow. So the liver kept on slipping, right? There was slippage of the liver, and sometimes it caused trauma to the liver as well. So Langenbach's resident was Morris. Morris was Langenbach's resident, and Morris designed a slight modification of the Langenbach retractor, which is known as the Morris retractor. So between Langenbach and Morris, you can see the difference. I hope you can appreciate the difference, that Langenbach has a narrower blade, whereas Morris has a much wider blade. And in addition to the wider blade, you can even see this concavity here. There is a slight concavity, which also helps in better visualization. So this one is a Morris retractor, which is bigger blade, and convexity is there. Again, it is used for retracting the liver edge. Some people like to put a gauze piece here and then retract the liver edge so that it does not cause trauma. And because of this concavity, you can visualize the gallbladder and the CBD and the junction of the cystic duct and the CBD better. It aids in your surgery. So please remember the difference between Langenbach and Morris retractor. Now, as you can see in the image, you can see a Doyen's retractor. Now, a Doyen's retractor is quite similar to a Morris retractor. How do you differentiate between a Doyen's and a Morris? So, Doyen's retractor, as you can see in the image, there is a bigger convexity and bigger concavity which is there. The curve is much more in a Doyen's retractor. The curve this way and the curve horizontally and vertically, both are more as compared to a Morris retractor. And this Doyen's retractor is used to retract the bladder during laparotomy. To retract the bladder, we will use the Doyen's retractor, which you can see in the image. Now, another retractor which is used during abdominal surgery is a Devers retractor, right? And you can see the Devers, it looks like a question mark, right? Looks like a question mark, you can see here. And you have a curve here. This curve is the one which is going to go inside the abdomen. And the surgeon is going to use this handle to retract the tissue. This curve is for better grip. But some people also utilize this end to retract. They can even utilize this end to retract superficial tissue, but the main utility is when you use the deeper end for abdominal surgeries. The blade thickness can vary. This one has a narrower blade, but you can have a Devers with a wider blade as well. Another retractor which you will see commonly in the surgical instrument set is a malleable retractor, which you can see in the image. Now, the term itself is self-explanatory. A malleable retractor, you can twist and turn it in any which way you want, and you can make it into whichever shape you want. So, usually the biggest use of this malleable retractor is when we are doing abdominal surgery, especially pelvic surgery. We've discussed in the past that while doing pelvic surgery, the bowel keeps on falling into the pelvis and it keeps disturbing the surgeon. So what the surgeon does is he curves the malleable retractor in a form of an arc, and the convex part, he utilizes it to push the bowel. So this convex part, he utilizes this to push the bowel, and the bowel remains up and it does not interfere in his surgery. So that is a malleable retractor, and these are all examples of non-self-retaining retractors where somebody has to actually retract these instruments. Now, self-retaining retractors make it easy because somebody doesn't have to retract them. There is constant pressure and a uniform amount of retraction which is happening. No postgraduate or no intern is scolded that, retract more, retract less. Those kind of issues don't happen. So the most common self-retaining retractor which you have seen is a mastoid retractor. You can see it in the image, and you must have read it in ENT as well. Again, it has two rings, and you can adjust the amount of retraction which you want. There is a lock also which you can see in the image. There is a lock which you can use to adjust the amount of retraction you want. The two prongs which are there, you can see that they get interlocked currently they're interlocked like this, but when you retract, they will open up and they will retract tissue, right? So they can get interlocked, and when you increase the retraction, they will just spread out and they'll retract superficial tissue. The next self-retaining retractor is a Balfour retractor. Now the Balfour retractor is mainly used for abdominal surgeries. And in the Balfour retractor, as you can see in the image, that you have a bar in which one of the blades is fixed and the other blade is mobile. Now, why do we want this? Because one blade is mobile, you can adjust the amount of retraction which you want, right? So we can adjust the amount of retraction, and then it can be fixed into that place. The fenestrations make it easier for you to visualize what is being retracted, and it also makes the instrument lighter. In a Balfour retractor, you can even add a bladder retractor to it, right? So a kind of a doyens can be added to it, and you can simultaneously retract the bladder as well. Now, one of the self-retaining retractors which oncosurgeons use frequently when abdominal surgeries are being done is a Bookwalter system. You can see in the image, this is quite a bulky retractor. So you have this semicircular ring which is first fixed to the OT table. So you fix that semicircular ring to the OT table, and then you have these multiple instruments which can just be attached to it using locks. You can attach multiple instruments, and multiple structures can be retracted in one go. And it makes the job of a surgeon while doing abdominal surgery much easier. So these were the various retractors used in surgery, commonly asked in the exam. One more which I've covered in thyroid surgery is a Joles thyroid retractor. This Joles thyroid retractor, I've shown you the image. You use one on each side to retract the superficial and the superior and the inferior thyroid flap. It was used earlier. These days, it's no longer used, but it has been asked in the exam, so you should know about the Joles thyroid retractor as well. So during surgery, there's often a requirement to take a suture, and to take a suture, we need a needle holder, right? And that's the next instrument which I want to show to you. This is quite a unique instrument, and it has been asked quite frequently in the exam as well. Now, if you see the needle holder, this is a needle holder. Again, we've discussed the two rings at the end. It has ratchets which are there, handle which is there. It has a box joint, and the blade of the needle holder is quite unique. And I want you to observe carefully here that this needle holder has crisscross serrations, right? There are crisscross serrations, and you can see that there is a groove here as well. So crisscross serrations and a groove. Now, if you compare this with an artery forceps, which we'll discuss later, but I just want to show you for the sake of comparison, an artery forceps here is only going to have transverse serrations, right? You can see here that this has just transverse, whereas this one has crisscross serrations. Now, any instrument which has transverse serrations only will crush the tissue. So if I want to hold an artery which is bleeding, I want to crush that artery, then I use this. But the reason why the needle holder has crisscross serrations is because we don't want the needle to move around, right? It prevents the needle from moving around in any axis. The other thing which you should know is how to hold the needle using a needle holder. So you can see here that this is my suture packet, and the suture packet conveys a lot of information. It conveys what is the nature of the suture material. In this case, it is silk. Then we know that there is a cutting needle here, right? That also we get to know. And I've told you many times previously that if you want to suture the skin or a tough tissue, you need to use cutting or reverse cutting needles. Whereas for delicate structures like bowel, bladder, CBD, we can use round body needles. So that is why before you take the suture and the needle, see if it's a cutting needle or a round body needle. Then what do? We open up the suture packet, and once we open the suture packet, you can see the needle here. You can see the needle, and we will hold the needle using the needle holder, and we draw out the thread. Now, we've discussed in the past that the needle is held at a 1/3, 2/3 junction. Okay. So let me just show you the parts of the needle. You can see here that this is the pointed end of the needle, right? This end where the thread is attached, this is known as the swaged end. It's not swag, it is the swaged end, okay? And the needle is held at a 1/3, 2/3 junction. So 1/3 from the swaged end and 2/3 from the pointed end. That's where we hold the needle, okay? Now, please don't handle the needle with your hands. Otherwise, you can get a needle stick injury, right? So supposing a lot of times this happens to me. Look, I'm left-handed, but the nurse assumes that I'm going to be right-handed. So whenever she's going to load the needle, she loads it for a right-handed person. Now, if I have to change it, I'm not going to use my hand. Otherwise, I can have a needle stick injury. So I'm going to use a forceps, and I just turn it around and I re-grip it with a left-handed grip, right? So I just turn it around and hold it with a left-handed grip. Never use your hands while handling needles. So you can see whenever I use the needle holder, the needle has to enter the tissue at right angles, right? So you can see here that the needle is entering the tissue at right angles. It enters the tissue. And because this is a moving cloth, so that's why this is getting lifted up. But you can see here, then you come out on the other side. And again, never use your hand, please. Use a tooth forceps to hold the needle and then guide it through from the other side. So don't use your hand, always use a tooth forceps to guide it out from the other side. And then you can take the various knots which we've discussed in the knots and suturing module earlier on in general surgery. Now, so I've told you about the needle holder. To hold needles like this and to hold tough structures like skin, fascia, we use a tooth dissecting forceps. This is a tooth dissecting forceps, and I want you to see here that this forceps is it has a spring action, right? This has a spring action. When you press it, it holds the tissue. When you leave it, it springs back into its normal position. And these serrations on the handle are for better grip. These serrations on the handle are for better grip, and you can see on one side there are two teeth here, and one side is a single tooth, and there is an interlocking effect. The single tooth goes and gets locked in between the two teeth on the other side, and that allows for better grip. But I want you to observe one thing here. When I hold this, there is some amount of trauma which happens to the tissue. You can see here that this mark is left here. This mark is left here. So tooth forceps will be traumatic. So it should be used for tough structures like skin, sheath, and fascia. Now, if you want a relatively atraumatic instrument where it does not cause much trauma, then you can use a plane dissecting forceps. This one is a plane dissecting forceps. Now, this plane dissecting forceps, again, you can see there are serrations on the outside for better grip, and there are transverse serrations inside, but there are no teeth here. There are transverse serrations, no teeth here. So this will cause less trauma as compared to a tooth forceps. This will cause less trauma as compared to the tooth forceps used for holding delicate structures like bowel, bladder. Those are the structures which you can hold with a plain forceps. Now, another type of forceps which you should know is a DeBakey's vascular forceps, right? And I want you to appreciate the difference between a DeBakey's vascular forceps and a plain forceps. Plain forceps, like I showed you, it has transverse serrations only, right? It has transverse serrations. Whereas a DeBakey's vascular forceps, it has a longitudinal groove running and it has these small teeth there. So there are 2 rows of teeth on one side and a single row on one side, and there is this interlocking effect which you get. So this is used for holding vessels. When we are doing vascular anastomosis, you can use a vascular forceps to hold the vessels. Why won't I use it with a plain forceps? Plain forceps is going to crush the vessel, whereas a DeBakey's vascular forceps does not do that, right? And it offers better grip. Another special forceps which we use is a Russian forceps. This is a Russian tissue forceps. And how do we identify this Russian tissue forceps? The end you can see here of this Russian tissue forceps, the end of this Russian forceps is clubbed. It is clubbed and it has multiple serrations which are transverse. You can see the transverse serrations, 2 lines of transverse serrations. Then it has a depression and it has these multiple small teeth which are there, which interlock with the other side. You can see here how beautifully they interlock. And these serrations offer better grip. Now, where do I use Russian forceps? For all my axillary clearances, right? Whenever I have to hold a lymph node or lymphatic tissue, I use a Russian forceps. Similarly, for neck dissection, when we have to clear lymph nodes, we use a Russian forceps because it offers better grip. So these are the commonly used forceps which you should know for the exam. Next, we'll talk about scissors, because we've spoken about how to take a suture. Now, to cut the suture or to dissect tissue, we need to use scissors. So those would be the next thing which we will discuss. So the first scissor which we need to discuss is the Mayo scissor. Right? Now, this Mayo scissor is a bulky, it is a heavy scissor which is used mainly for cutting sutures and for tough structures like sheath, fascias. Now, you can see in scissors usually have a screw joint. I told you there are 2 types of joints which can be there in instruments, a box and a screw joint. Scissors usually have a screw joint. You again have the 2 rings and you have the 2 blades which are there. Now, Mayo can either be a straight Mayo or a slightly curved Mayo, mainly used for cutting sutures and tough structures. Now, as interns or as residents, you will be asked to cut sutures or to assist sometimes. So just a word of advice, when you're asked to perform in the theater, cut a suture, it is always, you're anxious and the scissor doesn't seem to work and your hands are shaking there. So whenever you're using scissors, please make sure that you support the scissor with one hand. This offers better grip and better support. And when you have to cut the thread, you can even use your other hand to support the scissors, right? You can even use your other hand to support the scissors, and that makes your cut more precise, right? Of course, scissors are the worst instruments for left-handed people like me because they have been designed primarily for right-handed people. But over the years, I've learned how to use them. The other one is a Metzenbaum scissor. This Metzenbaum scissor is much lighter as compared to a Mayo scissor. This is known as a Metzenbaum dissecting scissor. As you can see, it is curved and it has a very long handle. You can see the distance between the handle and the blades. So the blades are quite small as compared to the handle in this scissors, right? It can be used for dissection and it can be used for cutting fine tissue as well. So this is a Metzenbaum scissor. Another thing which I want to tell you is that I've discussed this in the past, that first year postgraduates, their first surgery independently is an appendicectomy, and they usually take an intern to assist them, and they usually choose a female intern, right? Now these guys want to impress this female intern, so you'll see them doing this trick. What they'll do is they'll use the scissors and they'll palm the scissors like this. They'll keep the scissors like this, and they'll also be using one more instrument at the same time. So they've taken a suture, and after taking that suture, They are going to, like a James Bond act, they will bring out the scissors like this and they'll try to cut the tissue. Okay. So this is one of the ways how you can keep two instruments with you and operate. But when you're doing it to impress someone, usually the act does not work out. It fails. Right? So it's just something which I wanted to share with you. I've seen a lot of residents do this. Now, the third type of scissors is a Mackindor scissors. This is even finer than a Metzenbaum. You can see here this Mackindor scissor towards the tip. You can see how fine it is, how delicate it is. And it is used again for cutting delicate structures and for dissecting tissue while we are operating. So these are the various types of scissors which you should know about. Another thing which I've told you in general surgery while talking about sutures and knots, the three instruments which you need for skin suturing. Skin suturing, mind you need a needle holder, you need tooth forceps, and you need a straight Mayo scissors to cut the sutures, right? Now, this is asked quite frequently in your Viva as well. So, in your Viva, sometimes the examiner is going to ask you to arrange instruments in the order in which you're going to use them. So, till now, I've been telling you in that order only. In the next set of instruments which we are going to discuss, we are going to talk about the various forceps which are there, the plain forceps, the tooth forceps, and we'll talk about Cockers, Babcocks, Allis tissue forceps as well. So we've discussed about scissors, and the next set of instruments which we talk about are going to be the artery forceps and the special types of forceps which are used during surgery, and these are quite frequently asked in your entrance exams as well. So the first artery forceps which we need to discuss is the Spencer-Wells straight artery forceps. Now you can again see here that you have these two rings, you have a ratchet, you have a box joint, and you have this forceps which is here, which has transverse serrations. So these are used to hold arteries which are bleeding. So the bleeders which you get when you make an incision, you can hold them using a straight or a curved artery forceps. The straight one, this is a Spencer-Wells forceps. Again, you can have various sizes. This is a bigger straight forceps. This is a smaller one. You can see both of them are going to have transverse serrations, but they don't have any teeth present on them, right? Used for holding bleeders. You can also have curved artery forceps. You can see that this is a curved artery forceps. Again, it has transverse serrations like the straight ones. This is also a curved artery. This also has transverse serrations, and these are also used for holding tissue and specifically bleeders. The advantage of it being curved is you actually know which structure are you holding. You can see it, and you should hold the bleeder from the tip. Don't hold a lot of tissue, just hold it from the tip. Another special name which I want you to remember, again you can see these two sizes which are there, and the smallest artery forceps, the smallest curved artery forceps which you have is also known as a mosquito forceps, right? So this is a mosquito forceps because if I keep it on the table, it will resemble a mosquito, right? It resembles a mosquito. So this is a mosquito forceps, which is a curved, small curved artery which is there. Now the other types of tissue forceps which you should know about, very important for the exam, is an Allis tissue forceps. This one is an Allis tissue forceps. Again, the rings are there, the ratchet is there, handle is there, the box joint is there, and you can see at the end, you can see that there are multiple teeth there. There are multiple teeth which you can see here, and they interlock with the teeth on the other side, and they can grip the tissue really well. Now, because there are teeth present here, whichever tissue you grip, it is going to have some traumatic effect on that tissue. So, we will hold tough structures like the sheath, fascia, using an Allis forceps. Sometimes, you will even see surgeons holding skin with an Allis forceps. But how do we hold the skin? Like, supposing this is the skin, I will never apply it directly on the skin like this. I'll never apply it directly on the skin like this. Otherwise, you can see here, it is going to leave a bad mark. It will leave a bad mark, right? But from the inner aspect, I can hold the subcutaneous tissue and then I can retract the skin. I can hold the subcutaneous tissue and then I can retract the skin using an Allie's tissue forceps. Another one is a Babcock's tissue forceps. Now Babcock's tissue forceps, you can see here that the end of the Babcock's tissue forceps, you can see it has a curved end, and in the end you have these two fenestrations. I hope you can observe the fenestrations which are here, and there are no teeth. There are no teeth at the end. So there are fenestrations but no teeth. So what is the advantage of a Babcock's tissue forceps? This Babcock's tissue forceps, you can see some daylight between the two blades, right? There is some daylight between the two blades. So what is the advantage? You can hold tubular structures. I can hold a tubular structure using a Babcock's forceps. We can hold tubular structures like the fallopian tubes, the spermatic cord, the appendix. All of them can be held between the Babcock's, and it won't cause trauma to these hollow structures, right? So that is the utility of a Babcock's tissue forceps. Another tissue forceps is a Cocker's tissue forceps. This one is a Cocker's tissue forceps, and it's a heavy instrument. You can see the rings, the ratchet, the box joint, and you can see that there are transverse serrations. Like a artery forceps, there are transverse serrations, but there are two teeth on one side and a single tooth on one side, and there is interlocking which occurs, right? So when you apply a Cocker's forceps, it is going to be traumatic. So again, it is used for tough structures like sheath fascia. That's where we will use a Cocker's forceps. Another place where Cocker's forceps is used to crush the base of the appendix, right? While we are doing an appendectomy, to crush the base of the appendix, we will use this Cocker's, because that appendix specimen is anyways going to come out. If a patient is undergoing a hysterectomy, right, then you can even hold the cervix using a Cocker's forceps. But otherwise, if a hysterectomy is not being done, then you won't hold the cervix using this traumatic instrument. Even if you're doing a bowel resection and that piece of bowel needs to come out, you can hold it in between Cocker's, because it will cause trauma, but that tissue is already coming out of the body. So this is a Cocker's forceps. You should be able to identify Cocker's, Babcock's, and Allie's. These three are frequently asked in the exam, so you should be able to identify them. Another type of tissue forceps is a right angle tissue forceps, right? This is a right angle tissue forceps. You can see here that it resembles pretty much an artery forceps, but the end, there you can see that there is a right angle bend here. There is a right angle bend which is here. Again, it also has transverse serrations, and it has a right angle curve. Where is a right angle used? So supposing there is a pedicle, imagine that this finger of mine is the vascular pedicle. If I'm doing axillary dissection, this is a vein coming down from the axillary vein which I want to tie. So what am I going to do? I am going to pass my right angle. This is my right angle. I will pass my right angle below the artery or below the pedicle and get it on the other side. So I pass my right angle below the artery and get it out on the other side, and then I will open this up and I will ask the assistant to put a thread here. I draw that thread and now I can tie the vessel. I can draw that thread and then I can tie that vessel. Okay, so that is the utility of a right angle. It is usually used for ligating pedicles. This is a right angle forceps. Now, you can also have a curved artery, a long curved artery. This is also pretty much a right angle, but you can have a long curved artery with a more gradual curve to it. Not a right angle, a more gradual curve to it. That is known as a Kelly's forceps. So Kelly's doesn't have a right angle bend. It has a more gradual bend, as you can see in the image. That is a Kelly's forceps. The utility is the same. It can be used for dissection. It can be used to hold structures at depth. That is a Kelly's tissue forceps. So these are some of the tissue forceps which you should know about. Next, we're going to talk about laparoscopic instruments. I've covered all of them in the minimally invasive surgery module as well. But just for the sake of revision here in the instrument module, I'll show you these instruments once more. So, you know, the first thing which we need to achieve in laparoscopy is pneumoperitoneum. And we've discussed there are two ways of achieving pneumoperitoneum. It can either be the closed method in which we use the Verey's needle, or the open method in which I make an incision and then make the incision under vision and dissect right down till the peritoneum and open the peritoneum under vision. So the closed method uses the Verey's needle, and this Verey's needle has been asked many times in the exam. You can see that this is the Verey's needle. This is what the Verey's needle looks like. And you can see here the things which I want you to observe in the Verey's needle. The most important thing which I want you to observe is the beveled edge. This is the beveled edge of the Verey's needle. And how this functions, I'll just tell you in a minute. In addition to that, you also have a port through which you can put in saline and you can insufflate carbon dioxide as well. You know, carbon dioxide is the air which is the gas which we use during laparoscopy, and the pressure which we maintain is 10 to 14 millimeters of mercury for abdominal surgeries and 5 to 8 millimeters of mercury for mediastinal surgeries. Now, to insert the Verey's needle, you know that the Verey's needle is most commonly inserted in the infraumbilical region. So, I've shown you that video in the minimally invasive surgery module where we lift the abdominal wall and then we put in the Verey's needle. If a patient has had a previous surgery, then the Verey's needle is going to be put in the Palmer's point, which is 3 centimeters below and lateral to the costal margin in the mid-clavicular line. Now, when we insert the Verey's needle, this is what I want you to observe carefully. We know that this has a beveled edge. So I want you to look carefully. When I'm putting in the needle, you can see when it meets some resistance, this beveled edge goes inside, right? The blunt edge goes inside. When it meets with some resistance, the blunt edge goes inside and the cutting edge comes forward. So when there is resistance against the abdominal wall, you can see that the cutting end comes forward and it just pierces through the abdominal wall. It just pierces through the abdominal wall. But what happens is that once it has pierced through the abdominal wall, I want you to observe again that automatically the blunt tip has come forward. So this happens because we need to prevent injury to the bowel. So once it has cut through the abdominal wall, the blunt tip comes forward and it prevents injury to the underlying viscera. Now, how do we know whether the Verey's needle is in the peritoneal cavity or not? I have told you that we will either put a drop of water here at the port, at the opening, and if it gets sucked inside, right, then we know we are in the peritoneum. Or we can inject 10 cc of saline. It should freely go in and you should not be able to aspirate it out again. That's when we know that the Verey's needle is in place. Once it is in place, we are going to insufflate carbon dioxide, which is usually insufflated at the rate of 1 to 4 liters per minute, right? And once we've achieved the desired pressure, that's when you're going to insert the trocars. Now, you know, if I've used the Verey's needle method, then I need to use a sharp trocar. This one is a sharp trocar. It can either be a 10 millimeter or it can be a 5 millimeter trocar. These are sharp. You can see that they have a sharp edge. So these sharp trocars, we are going to insert the sharp trocar through the abdominal wall into the peritoneal cavity. And as I mentioned previously, only the first trocar is inserted blindly. I've even shown you a video in the minimally invasive surgery module. Only the first trocar is inserted blindly. Rest all trocars are inserted under vision. I've also shared the story with you that the postgraduate who inserted it with a lot of force and injured the bowel. If you injure the bowel with this, what do? We have to convert to an open surgery, but we keep the port in position to see the actual site of injury. Now, if you're using the open methods or the Hassan's method, where under vision I've made a cut, there we will use a blunt trocar. You can see in the image, you can see the Hassan's or the blunt trocar. That's what we use if we are using the Hassan's or the open method. An OptiPort or a VisiPort also, I have told you, it has a transparent end and you can insert the camera while putting it through the abdominal wall. So you know where you're going and the chances of injury to vital structures are greatly reduced. Now, once we've inserted the trocar, then we have to put in instruments through the trocar, right? So once we put in the trocar, then we are going to, this is the sheath through which I'm going to put in instruments, right? And the instruments for laparoscopy, as we have discussed previously, these are long black instruments. As you can see here, that these are long black instruments, right? You can see how long they are, and they are black, and only the tip is exposed. Now, what is the reason of having such a long instrument? Firstly, the reason for having a long instrument is because I have to go inside the abdominal cavity, and that's where we are operating. In obese patients, they're even longer. Right? Now, you can see that there are two rings for your fingers to go in. There are two rings for the fingers to go in. You can rotate the instrument. Look, if you look here, I can rotate the instrument from here. I can rotate it, and it gets rotated in the front. And this pointed object which is coming out here is for the cautery to go in. You can attach the cautery lead here, and when you attach the cautery current will only come out through the tip. Why? Because this entire black thing which is here is insulated. That is the insulation around the instrument, and it prevents the leak of current. Okay, so what happens is that this is my trocar, this is my instrument, it goes through the trocar, through the abdominal wall, and now I can open it, I can grasp structures, I can attach the cautery. Okay? Few things which I want you to know. So this is a Maryland's dissector. This is the workhorse of laparoscopic surgery. You can see it is a Maryland's dissector, and it resembles your artery forceps in terms of serrations. It has transverse serrations, and this is known as a Maryland's dissector. This one here are the scissors which you use. These are the scissors, right? The laparoscopic scissors which you can use for cutting. And this one is a blunt grasper. You can see here that this is a grasper, and you can hold the tissue with this. The advantage of this grasper is that if you see here that there is a lock present here as well. So I can hold the instrument, and then I can lock it in place also. And I've told you can even have a toothed grasper. There is a crocodile grasper also which is there. Shown you the images for that. All of them are used for holding structures during laparoscopy. A toothed grasper is held by the assistant during lap chole. You hold the fundus of the gallbladder, and then you retract the fundus of the gallbladder using a toothed grasper. So these are the instruments which are used in laparoscopy. If the insulation breaks down, what is going to happen? I've attached the cautery current here. If the insulation breaks down, then current will leak from the instrument, and the instrument is going through a metallic trocar, right? So if the insulation is broken down in an old set, then current will come into the trocar. And because the trocar is metallic, it is also going to leak out current, and it can burn the abdominal wall. This is known as capacitance, right? And how can I prevent capacitance? I can prevent capacitance by having a completely plastic trocar, because plastic does not conduct current. One more thing is direct coupling or capacitance coupling. Now, what does that mean? Look, supposing you have this instrument which we are using, and I have another instrument which I'm using during laparoscopy. Now the insulation of this instrument, this one coming through the trocar, the insulation is broken down. And this instrument now comes in contact with this, right? This comes in contact with this. So current will pass from this instrument, which is on the top, to the instrument below, right? And it is touching the edge, it is touching the tip which is exposed. So current will leak out from this tip as well. And if this tip is in contact with the bowel, then the bowel or any viscera can get injured. This is known as capacitance coupling or direct coupling. And how do we prevent it? We prevent it by triangulation. I told you one of the principles of laparoscopic surgery is triangulation, where you make sure that the instruments are not clashing with each other, right? And by preventing that triangulation, we can prevent this direct coupling or capacitance coupling as well. So these are the laparoscopic instruments which you should know about. I have already told you about single incision laparoscopic surgery. This is the Sills port, which you can see here. It has 3 openings. Through one port, you can put in multiple instruments and do the same surgery with a single port rather than multiple ports being inserted. And in robotic surgery, we've discussed the Da Vinci robotic system which is used. The Da Vinci robotic system is the system which is being used currently. It works on the master and slave concept. The details are there in the minimally invasive surgery module. Just recently, there was a patient of mine where she had a single lesion, a breast cancer lesion on the 9th rib. And post her chemotherapy, we had to resect that 9th rib. So we made a thoracotomy incision. And once we made the thoracotomy incision and we reached down till the rib, then we use a periosteal elevator to elevate the periosteum to clean up the rib so that we can resect it. So we use a Farabouf's periosteal elevator. Now this periosteal elevator, you can see here that it has there's a handle and there are some serrations present just before the tip. So these serrations are to put your thumb there for better grip so that it does not slip. And you would see that the blade is slightly curved and it's a sharp blade which helps in lifting the periosteum. So wherever you want the periosteum to be lifted, we use a periosteal elevator. Commonly it's a Farabouf's periosteal elevator. Now once I've lifted the periosteum and I cut the attachments, the intercostal muscles which are there, we can use a rib respiratory for whatever attachments are still left behind. We can use a rib respiratory and we put in this rib respiratory, and this rib respiratory has a sharp blade. There is a sharp blade here, and when you move it across the rib, it just cuts out all the attachments so that just the rib is left and you can easily cut it after that. Now commonly in the college exams they ask you how to localize the rib respiratory, because there is a separate rib respiratory for left and separate for right. So always remember, to determine the side, you have to put the respiratory in such a way so that the handle faces laterally. The convexity should be upwards. So convexity should be upwards and the tip should face downwards. That is how you need to arrange it. The handle is going laterally, convexity upwards, tip downwards. That is how you can determine if it is a left-sided respiratory or a right-sided respiratory. So once I've removed all the attachments, now is the time to cut the rib, right? So you have these 2 types of rib cutters. This is the one which I use at my hospital. It's a Geertz rib cutter, and you can see it is the way it is made. You can easily hook the rib through this. You just hook the rib, and when you press the handle, it easily cuts the rib. Now you would see that all these are heavy instruments, right? Because you're cutting bone, you want a heavy sturdy instrument, and there is a double lever attached here. One is here, one is here. So 2 levers, because it magnifies the effort which you're putting. So whatever effort I put, this lever is going to magnify that effort and it would easily be able to cut that rib. This you can see is a dolphin rib cutter. Again, you can see it is in the shape of a dolphin, looks like a dolphin. Now this is a blunt tip. This is the one which goes below the rib. This is blunt, and the top one is the sharp one, right? So you want to avoid having both sharp edges because you don't want to injure the pleura beneath and cause pneumothorax or injury to the lung. So which is why this one is blunt, this one is sharp, and you can easily cut the rib. A bone cutter, which Dr. Abbas has taught you in orthopedics, both the edges would be sharp. Whereas in the rib, I want the edge which is going below that to be blunt so that there is no injury to the underlying structures. Now, once I cut that 9th rib, there was a sharp edge which was left behind. Now, this sharp edge can puncture the pleura, cause pneumothorax. So, once you cut the bone or the rib, you use a bone nibbler to nibble at the edges so that there is no sharp edge left behind. And you can see here this bone nibbler, it has these two edges which are not very sharp. They're actually slightly cup shaped, and they just help you to nibble at the edges and make them smooth so that no sharp edges left behind. Again, there is a double lever here to magnify the effort which you're putting. Now, if supposing I have to do a lung biopsy, or if I'm doing a thoracotomy to do a lung procedure, then once I've done the thoracotomy using the instruments which I've just told you, then to retract the lung, we use an Allison's lung retractor. Now, the advantage of this Allison's lung retractor, you can see that it has a handle and the blade is fenestrated. You can see that the blade is fenestrated. So this fenestrated blade helps us because it will easily retract the lung, and the lung can still expand and be in between the fenestrations, right? And because of these fenestrations, there's not much pressure on the lung. So there can't be any pressure necrosis. If it was a solid blade, then there are chances of pressure injury happening to the lung, which is avoided using this Allison's lung retractor. Now, supposing there is an area of the lung which I want to biopsy, right? You know, lung is a very vascular organ. So I can't just start cutting that area. It'll bleed a lot. So we put this lung holding forceps. You can see it's a triangular forceps. It has a unique shape, so you can easily identify it. So the implicated area, I will just put this triangular thing there, and that is going to act as a hemostatic thing, and it will also stabilize that area so that I can easily resect and suture there. You can see that it has transverse serrations. There are transverse serrations. So you can grip that area and then you can operate there. You can remove that area. You can suture that area. That is why the fenestration is there. The gap is there so that you can resect and you can suture using this fenestration. So for thyroid surgery, this is no longer used now, Joel's thyroid retractor, but it has been asked in the entrance exams a few times. You know that for thyroid surgery, we make the incision, then we have to raise the flaps. We raise the flaps. To fix the flaps and to retract the flaps, we use Joel's thyroid retractor. And one is used on each side, right? So one on this side, one on this side, and you can see that there are two clips here. These are almost like towel clips. So one holds the superior flap, one holds the inferior flap on each side. So two Joel's thyroid retractors are used during surgery. Again, a unique design, you can't forget it. This is a Cocker's thyroid dissector. So Cocker's thyroid dissector is used for dissecting the superior pole of the thyroid. It is used for dissecting the superior pole of thyroid. Don't confuse this with the periosteal elevator. I've already told you periosteal elevator. You have that, those serrations for better grip there, and it has a sharp end. There is no sharp end here. This is just for blunt dissection of the superior pole of thyroid. This one is an aneurysm needle. Now, if you look closely, the handle is like the handle of a Bard Parker handle, a similar handle, but the needle is curved, and at the end you have an eye, right? It is curved and there is an eye. So where exactly is the aneurysm needle used? So the name itself is suggesting that you can pass it below the aneurysm, right? Supposing this is the aneurysm, I can pass it below the aneurysm, and through the eye, I put in a suture, right? I can pass a suture through this, and then I can easily pass the ligature around the aneurysm, right? So it becomes easy for me to ligate the vessel or hook the vessel. This can also be used during venesection. Venesection, you know, is commonly done in the great saphenous vein. So to hook, I just put this aneurysm needle, put a ligature, get it out from here, and I can ligate that vessel. So this is an aneurysm needle. This is one of the favorite instruments which the examiner asks you during your viva in final year. This is a suprapubic cystolithotomy forceps. It has a very unique design, so you can't go wrong in identifying it. But yes, then the examiner also asks you, how do you hold it? So first, let me just explain the design to you. So you have one ring, one closed ring for your thumb, where the thumb goes, and then you have an open ring here. This is for the other 4 fingers. So 4 fingers on one side, thumb goes through the closed ring. So you hold it like this, and you can see here that there is no lock here. No lock, because if you're holding a stone and if you have a lock, you're going to crush the hell out of that stone and it'll break. You don't want that, right? So no stone is there, and you can see some serrations here. There are some serrations or slight stud-like things which help in better gripping of the stone. So 4 fingers on one side, thumb on one side, you hold it like this and you lift out the stone. There is no lock there so that you don't break the stone. Now that was a suprapubic cystolithotomy forceps. This one is a pyelolithotomy forceps. Pyelolithotomy is when you make an incision in the renal pelvis and you extract the stone. Now you can have a stone in the superior calyx or the lower calyx or the middle calyx. So you can see that there are different angulations, right? There are different angulations for different calyces, and you can easily remove the stone. Again, because it is a stone removing forceps, there is no lock or ratchets. No lock or no ratchets are there. And you can see that there are transverse serrations. For better grip, there are transverse serrations present in pyelolithotomy forceps. These transverse serrations are very important because these are the ones which will help in differentiating it from a Desjardins collidicolithotomy forceps, which is the next one which I'm going to show you. So please remember, pyelolithotomy forceps, different angulations, used for removing stones when we are doing a pyelolithotomy. This is a Desjardins collidicolithotomy forceps. Again, this forceps is used to get stones out of the CBD. And you can see here, again, no ratchets, no lock so that you don't break the stone, and no serrations are here. No serrations are present, and that is what helps in differentiating it from the pyelolithotomy forceps. So please remember this difference. This was also asked in the viva. This is an ovum forceps, right? This was one of the options which was there in this year's FMG exam. So ovum forceps is it has 2 cup-shaped ends at the cup-shaped ends, so you can easily extract tissue, and again you will see that there is no ratchet here, so it doesn't get locked. No lock is present. Mainly used for gynecological procedures to get placental fragments out, but in surgery we use it to get gallstones out of a gallbladder, right? Sometimes the gallbladder is not coming out of the small port after you've done a laparoscopic cholecystectomy. You're trying to pull out the gallbladder through a small port opening. It's not coming out. So we put this ovum forceps, we remove the stones, we empty the gallbladder, and then it comes out through that port site. This is a Cheadle's forceps. You must have seen a Cheadle's forceps being handled by a nurse, usually kept on the dressing trolley, or it is used. So this is usually kept in the dressing trolley, dipped in antiseptic solution. dipped in antiseptic solution, and it is used to pick up gauze pieces and other sterile instruments and hand it over to the surgeon or to the other nurse. Again, there is no lock. It is angulated. This is a Cheadle's forceps, which you would see on a dressing trolley usually. Now, a couple of vascular clamps. This is quite a popular vascular clamp known as a bulldog clamp. And vascular clamps, you would always see there are transverse serrations, but there is a vertical groove running here. There is a vertical groove running and there are fine transverse serrations. This is a small stout instrument and it has a spring-loaded action, right? Spring-loaded action is there. So this is used for temporary occlusion. This is used for temporary occlusion of peripheral vessels. It is not very big, so it would be used for smaller vessels. Temporary occlusion of peripheral vessels when you're doing some vascular surgery, or if there is a vessel bleeding and you temporarily want to occlude it during some other procedure, you will use a bulldog clamp. This one is a bigger clamp, a bulkier clamp. This is a Satinsky vascular clamp. You can see here that it has ratchet, so you can lock it, and it is curved. So again, you have a vertical groove running and you have these transverse serrations. And the reason why it is curved, it is for two reasons. One, when you apply it, so you can see here when we've applied it over a vessel, this is the vessel where we've applied it. So it enables clear vision. If it was straight, you cannot see properly. So this curved thing enables clear vision and you can suture easily. Right? Because it is curved, it gives adequate space for your needle holder to move and you can suture easily. So again, you will use a Satinsky vascular clamp on both the sides. Supposing there is a major vessel, say IVC, which is bleeding, you apply Satinsky clamps, you can repair it, and then you can release the clamps after that. Okay. So this is a bigger clamp as compared to a bulldog clamp. Now, when we have to do resection and anastomosis of bowel, right? Anastomose the bowel, you know, I want two ends, there are two ends of the bowel which are there. So we hold those two ends using a Doyen's intestinal clamp. This has also been asked in the exam. This Doyen's intestinal clamp, unlike the vascular clamps which all had transverse serrations, this has longitudinal serrations. It has longitudinal serrations. There is a lock which is there, ratchet is there, ratchets are there to lock it. But even if you apply the last ratchet, you would see that there is some daylight between the two blades. The two blades of the intestinal retractor, there would be some space between the two blades, so it doesn't crush the bowel so hard that you lose the vascularity of the bowel. There's still some daylight present between the two blades, and you can see here that you apply these one clamp on either side and then the surgeon can carry out the anastomosis. This is a non-crushing clamp because you don't have any teeth here, right? It's non-toothed, non-crushing clamp. On the other hand, you have a Pear's crushing clamp, right? Pear's crushing clamp, you can see it has a very unique design. It has a spring-loaded action which is there. And again, as I told you, there are vertical or longitudinal serrations, but it has a tooth at the end. So because of this tooth, this is a crushing, this would become crushing, it will crush the bowel. So where do I use it? Supposing, look, this is the bowel. Supposing this is the bowel, and supposing there is a lesion here which I want to remove. Okay. Now this is the blood supply. I want to remove this lesion. So I'm going to apply one clamp on this side, one clamp on this side. These are your non-crushing clamps. Okay. But when I remove this segment, these two clamps will be on these two sides, which I want to anastomose again with each other. But on the specimen which is going to be removed, I don't mind if that gets crushed because that is not, I don't want to utilize it. So here I will apply 1 and I will apply 2 crushing clamps. These 2 will be the crushing clamps which would be then removed along with the specimen. These 2 brown ones are the non-crushing clamps which I will then use for anastomosis like I showed you. Okay. So biopsy techniques I've already covered in the breast module. This is a punch biopsy instrument. This is a punch biopsy instrument which is used for carrying out incisional biopsies. That means you just take a chunk of the tumor or the tissue. This is a true cut biopsy gun. True cut biopsy gun which is there. 8 to 18 gauge can be used. This is the investigation of choice for breast lesions, for soft tissue sarcomas, and a truss guided true cut biopsy for prostate. All this has been covered in the breast module in detail. I've told you about other biopsy techniques there as well. These 2 instruments have also been covered in the plastic surgery module. A Humbee's knife has been asked many times in the exam. Humbee's knife is used for raising skin grafts. These are used for raising skin grafts. And this is the manual method to raise skin grafts. You can adjust the thickness of the graft which you want. An electric dermatome, as the name suggests, is the electric method to raise skin grafts. Humbee's knife you all should be able to identify. It's been asked many times in the exam. In this year's INI CET exam, very simple questions were asked. IV cannulas, I've covered in the very first module. You should go through IV cannulas. Foley's catheters, I've covered in the bladder and the urethra module. Please go through those Foley's catheters. And I have told you in the thoracic trauma module about an underwater seal bag. This is an underwater seal bag where you will see that there is a mark here. It is conical like this. You have one end of the tube running right down and you fill it with water till this point, so that one end of the tube is always submerged. And why do we want one end of the tube to be submerged? So that air can bubble out but air doesn't get sucked inside, right? When the patient breathes in, again air won't go inside, right? Because of the water, air is not going to go inside. So this is an underwater seal which is connected with intercostal tube, ICT. This is a Urobag which is connected to a Foley's catheter or a drain. You can appreciate the difference between the two. It doesn't have a pipe running in between, doesn't have a marking for a water column. So these were some additional instruments which I physically could not arrange. Instruments, invariably one instrument is asked in all entrance exams, and common procedures, one more question is there in all entrance exams. But for your Viva, these instrument Vivas carry 10 to 20 marks. So you should take out some time to go through these instruments before the exam.